Thank you for joining our webinar this afternoon. I'm Caitlin Crossley from Optimity Advisors and I'll be your moderator. Dr. Niamh Lennox-Trigani will be presenting. This webinar is about design and delivery. Are we designing an agile organization that is really connected to our consumers and delivers what matters? Before Niamh starts, I'd like to introduce today's speaker, explain how to ask a question using GoToWebinar, and finally how to access the webinar recording. Dr. Niamh Lennox-Trigani is a managing consultant at Optimity Advisors and leads our health, care and local government practice. Niamh's detailed profile is available on our website, or you can find her on LinkedIn. Today's webinar on design and delivery is the third of a series of webinars we are hosting on health and transformation. Before we get started, I'd like to mention that we welcome your questions throughout the webinar. All you need to do is type yours into the question window, which for some is the sixth blue bar down on the GoToWebinar control panel, and hit submit. We'll get to as many questions as we can during the Q&A session after the main presentation. Finally, we're recording today's webinar and we'll post it on the Optimity Advisors website. We'll send you an email once it's up in case you want to watch it again or forward it along to a colleague. Without further ado, I'd like to turn the program over to Niamh.
Thank you, Caitlin, and good afternoon, everybody. Today's webinar will explore how health and care systems can design and deliver new ways of working which enable everyone in the system to understand what and how they can be working differently. Today we'll share our experience of how health and care systems can start to work in a different way and model the kind of collaborative practice working with the communities they serve. We will share the tools that we use to support the change and our experiences in using them. So the story so far. Our previous webinar introduced a framework for thinking about new ways of working. To quickly recap, the assumptions that underpin this framework include, first of all, the starting point should always be what do local people want or need from health and care. This requires a fundamental rethink of how services are designed around the needs of the population. Organisations already have lots of transformational ideas and capability in-house and could harness it much more effectively. The kind of accountability that is more meaningful to all of us is not up and down, but works peer-to-peer. Our colleagues and consumers are the people who matter to us. Their feedback is in real time. And openness to learning from mistakes is absolutely critical. This is the only way to improve quality sustainably and requires trust and honesty, one of our biggest cultural challenges in health and care today. So what are the kind of questions you need to ask as a system as you start out on this journey? Today we're focusing on the two questions related to design and delivery. In webinar 2, we talked about leading differently and harnessing the talent you have in order to provide the kind of services that people want and need to stay well for longer, and when they're unwell, deliver the right, high quality, safe services at the right time and in the right place. To do this, we talked about how leaders need to unlock the collective intelligence of their organizations to work as a powerful, collaborative, transformational network. To unlock the collective intelligence across a health and care system, the leadership need to empower their operational managers and frontline staff to behave differently. Today we want to talk more about how you do this and how you create a culture of peer accountability by redesigning a system that creates the right conditions for this to happen and reinforces those conditions day in and day out. In webinar 1, we talked about our approach rooted in the principles of wiki management. Articulating the ambition and motivation is a prerequisite for beginning the design and delivery part of the transformation journey. Part of this process of telling the story of transformation is being able to talk about how the system will operate in a very different, more joined up way than it does today. We recognise that we're not operating in the context of certainty here. We are instead living and working in a situation where past experience is no longer a reliable predictor. Cause and effect relationships are indiscernible at times. Even experts fail to make sense of conflicting signals, and there is high-frequency, multi-dimensional turbulence at scale, and all of these are not easily susceptible to logical analysis. We know that our current health and welfare institutions and the systems were built in an age of much greater certainty. We have to reshape them to cope with uncertainty. In moving on to the design and delivery stages of the transformation journey, our approach is based on the fundamental principle that organisations working within health and care systems have the collective intelligence and clinical expertise to transform their own organisations. The health and care system has always referred to the workforce as its greatest asset, and there's no doubt that this is the case. I would argue that as an asset, it is massively underutilised. Not in terms of productivity. We know the NHS workforce is amongst the most productive in the world. We have 40% fewer acute beds today than in 2001, 97% more activity in medical specialties, and the length of stay has halved in that time. But their collective intelligence is rarely effectively harnessed, particularly to generate and test new ideas. Initiatives such as the annual NHS Change Day and the Academy of Fabulous Stuff have tried to create fora in which anyone can share and create ideas that work, or learnings about new ideas they are still testing and refining. Communities of practice and learning networks have been strategies long used in the NHS to promote learning and innovation. Many such initiatives, though, have remained external to the everyday working lives and experiences of NHS and social care staff and the people they care for. It's only by making learning together part of the everyday that we will really embed learning and innovation as a new way of working. I would also argue that by using the term workforce, we are limiting how we think about the human capital available to the system to generate these ideas and make them happen. Service users, their carers and friends, employers, community groups, all have an interest in improving an individual's and the wider population's health, yet we so rarely embrace their skills and experience. There are two key design principles we focus on with health and care systems as they work to develop new ways of working. The first one of these is to harness this collective intelligence. You need to create the conditions that enable people to come together in open conversations, to collaborate and co-design new ways of working, test them, learn together, rapidly iterate and share learning across the system. To embed this as a way of working, you must hold people accountable to their peers and the people they serve rather than through an upward management chain. This is where we get the most meaningful feedback. Let's first of all reflect on how we manage transformation programs today. Traditionally, we take the hierarchies of the partner organizations and then replicate it as a program management office to deliver the change as a separate function. The principles on which the PMO operates are relationships based on command and control, ideas generated at or near the top, being in charge and in control, and lots of systems and processes that dominate. This works really well when you have lots of certainty, but as we know in health and care systems today, there is little that is certain about the transformation we're trying to undertake. If we use a hierarchical approach to complex change, it's hardly a surprise that impact is limited. The widely cited number is 75% of change initiatives fail in full or part. And change takes longer than we hope if it happens in the way we anticipated at all. Equally, if the change vehicle itself replicates the command and control structures you've always had, it's hardly a surprise if no one really buys that the system is really committed to change. In order to move from organisational and functional silos, which is where we are today, to a more transformative and integrated service that's really centred around the needs of the person and deliver value, we need to put in place a transformation process that echoes a new, more networked and agile system that we aspire to become. This approach removes the needs for armies of project managers being recruited externally and the team being seen as removed from the day-to-day work of the health and social care system, and even further removed from the experiences of the people who sit at the centre of services. It ensures real ownership of the transformation, sits where it should, at the front line with caregivers, both paid and unpaid. In our experience, by creating the space for these networks, you create the conditions for genuine culture and behaviour change, with peer-to-peer accountability generating a momentum and greater responsiveness and innovation that's often constrained by upward management chains. This is not a short-term process and requires everyone in the system to be consistent in their behaviour and ensuring that behaviour mirrors the language they use, that they walk the talk. Research tells us that where population-based integrated systems of care have benefited people most measurably, the conditions which have enabled the change have included clear vision and narrative. We talked about how you develop this in webinar 2. This reinforces the importance not just of communicating this, but living it and breathing it today. If you set out a vision of services that are person-centred, coordinated, seamless, and enabling greater well-being, then you should include service users, carers, and the local community in the design and delivery of the new system from the start. Aligning incentives, and by this we don't just mean financial, is really important. There is little point in talking about peer-to-peer accountability or being accountable to the people that you serve if we still work with performance management that relies on line manager feedback. Amongst integration pioneers in England, there has been much talk about workforce transformation and the creation of new roles such as care navigators. Whilst there is certainly a place for exploring potential new roles, there is much more power in exploring how current roles could adapt and become more holistic, in some cases returning to their historical roots, and thus simplifying a system we have made more complex by creating unnecessary silos. When asking yourself if the system is resourced for the change, in our experience the most important question is, in resourcing for change, what are we going to stop doing? This rarely happens as a starting point, but is absolutely essential. Without doing this, you risk overburdening people and communicating a message that seems to say, we don't really think this is going to work, so just keep doing what you've always done as well, just in case. As individuals, what motivates us to achieve, according to Maslow, is the desire for building and sustaining social relationships, building our own status and self-esteem in relation to others, and having a sense of accomplishment. These are all very important when we think about the operating model of a health and care system. Clearly, the key difference is that the system motivation rests critically on firmly established shared sense of purpose and an operating model or ways of working every day that reinforce this purpose. It doesn't seem to contradict it or get in the way. Without that, there's a risk that individual organisational motivations and interests, and the way things have always been done around here, will be an automatic default. The system's leadership role is to set out why. You now need to create the space for others who are better positioned to know what is right to decide on the what and the how. Before we move on, though, there is a role for system leaders in being accountable. But in our experience in guiding health and care systems through change, we've shown that this is done in quite a different way from the traditional approach. There are well-established hierarchies within health and social care organisations where command and control has been the main governance model for decades. Statutory organisations in their own right, governed by internal bodies and accountable to regulators and national bodies for their performance, health and care organisations often cite a tension between these accountabilities and a desire for more system integration. National bodies, including regulators, have signalled a willingness to create space for a new way of working and being accountable, as long as it meets the triple aim of better population health outcomes, better quality, safer care, and better value for money. Instead, we help system leaders design a governance model that allows them to put in place different ways of working that will enable them to collaborate and be innovative. The rules for accountability in these circumstances are a bit different. Using Mark Moore's strategic triangle, the system partners, and this includes the community served, need to agree what the uniting purpose is that's of value to all of them, the legitimacy with which they as a collective have the power to deliver the purpose and be transparently accountable, and their ability to create the conditions for the network to operate in fundamentally different ways, to provide them with a safe place to test new ideas, fail as often as necessary to learn, then succeed, and play an active role in unblocking those constraints. This formal accountability mechanisms, yes, but more importantly, real and active ownership of actions and holding each other to account for these. Sometimes this will lead to conflict, but that conflict should not be avoided for the sake of a quiet life or preserving delicate relationships. If they are that delicate, they cannot deliver the kind of difficult change you need. In our experience, working through the conflict strengthens most working relationships. This means thinking really hard about creating the conditions that will unlock the collective intelligence across the system. One of the most powerful ways of doing this is bringing together groups who have rarely had the opportunity to work together before. And we include service users and their carers in this to explore the challenges the services face and the ideas they have for delivering better quality services or reimagining them entirely. This process needs to be facilitated and supported, especially when it's new to people. And we use a number of techniques, including accelerated design and open space approaches to facilitate this. What emerges from this is what John Cotter terms a dual operating system. It recognizes that organizations that have been around for some time as hierarchies cannot become networks overnight, or in some cases ever, because of regulatory or other constraints. Instead, Cotter proposes that organizations build innovation networks that sit alongside the hierarchy, but are populated by volunteers from the hierarchy who are released from at least part of the day job to work with a network or coalition of others from across the organization or system on a specific idea. It's governed by 5 principles. You create networks of champions who are committed to the idea. You empower them to free up some of their own time by reprioritizing or delegating. You harness the collective intelligence of the group as they move from taking direction from senior managers to developing, testing, and refining their own ideas. Focus on some quick wins, initiatives that you know will have high impact, building on existing strengths, and then communicate the success widely, repeatedly, and loudly. And finally, govern the dual operating system through facilitation. This network is enabled by a different set of management practices from the traditional command and control. Rod Collins describes the role of the manager in a network as a collaboration facilitator. They facilitate co-creative meetings. This is a very different role for most managers, and it's a completely different experience from most of the meetings they currently attend. To understand what the starting point for a health and care system is on this journey to building these networks, and they are likely to be multiple, and in fact you may find they already exist in part, we use communication network analysis tools to understand who speaks to whom when they have a particular challenge. This paints a picture that takes you beyond the formal team structures of organizations in a system and helps you understand who already works across organisational boundaries and works with service users so that you can encourage these people to become active members of the new innovation networks that you're building. These networks are the engines of change and innovation in a health and care system. In order to do this effectively, they have to be self-managing systems. Remember the Maslow triangle? We all want to achieve a sense of accomplishment and want to do this as a member of a wider social group. This is the foundation of self-managed teams, which have been the basis of organisations such as W.L. Gore since its foundation in 1958. The starting point is trusting groups of people to own an idea, make decisions that need to be made about making it happen, based on the premise that one manager is not cleverer than, say, 6 people who are closest to the problems they're trying to solve, and account to each other for delivery. One approach that we use with these self-managing groups that helps them think in a different way about a problem and to test their innovations and ideas in a way that makes holding each other to account much more transparent is using theories of change or logic models. Long used in research and evaluation circles and occasionally in program management, these provide a helpful framework for groups to test out new ideas by setting out the objective and goal of the idea, what they think the benefits or outcomes are going to be, what inputs and activities they will need to deliver the idea, and how they're going to measure the realization of the benefits, and when they are going to report to each other and the system leaders on these and incorporate that learning rapidly to iterate and refine the model. We will talk about this approach in more detail in Webinar 4, as it's also a great way of embedding learning and continuous improvement in systems. So you've set up your self-managing network, which has a particular set of challenges in their sights and have been given the power and the permission to do what they think needs to be done to deliver a much better and maybe completely different service. That sounds great, but chances are they're still doing the J job too. So they need to be given permission to stop doing a bunch of stuff that does nothing to contribute to delivering value. I might also need to be given permission to step outside the traditional role boundaries they have always worked within. We know this is easier said than done, and there are structural and cultural barriers, especially between health and social care workers, that make this even harder. But it is a fundamental task of system leaders, and this is where they bring to bear their collective intelligence to resolve these challenges. It also requires us to look beyond the traditional boundaries of our resources. I go back to my earlier comment about using the term workforce. This automatically limits us to think about paid staff as the only system resource. When you take a whole systems perspective, this resource is in fact the whole community. A really good example of how this is just beginning to change in the NHS is Good Sam. This is an app that has been developed by the London Air Ambulance to recruit trained first aiders from local communities across London who have medical or first aid training. All of these volunteers can be geolocated using the app should an emergency in their locality occur. The nearest responder is contacted first and asked if they can attend the scene, and the system daisy chains through until an available responder is located. We have the tools to create social movements like this. Think of the locally available collective intelligence we could tap into. Another example is time banking, which has been much talked about in the UK public sector and has been slow to grow, but it is an invaluable resource in designing innovative new services. We're not going to spend too much time talking about technology enablers for transformation here. Technology has great power both to accelerate change, but it can also put up more barriers to change. How it is used is entirely in our hands. We're probably further ahead in our use of technology for empowering the community to self-care with information and tools, although we still have a tendency to impose a service-centric view of what they need. Involving community groups in the design and delivery of such tools, and if possible letting them take the lead in this with advice and support from both health and social care professionals, creates the kind of social movement needed to make self-care a real community good with demonstrable benefits. We often focus in transformation programs on processes as the change to a process, or a bit of supporting infrastructure is very tangible. These are only really powerful, though, if we use them as a proxy for fundamental change. If you have a great new application that really engages local communities in service design and delivery, use it as part of a program that challenges the way things work around here and delivers a service built around the actual needs of the user and their community. That is transformative. Ask your leaders to remove any information governance or other obstacles that stand in the way of you delivering these kinds of transformations. It's not easy. It takes time and requires people, including, I say again, service users, to be given permission to do different things differently and given permission to stop doing a lot of stuff they're doing today that's not delivering value to local communities. This needs to be the commitment that their leaders make to them and the cover that the leaders give the networks of innovators and idea generators to let them get on with what they do best, design and deliver the highest quality, safest services that enable people to lead longer, healthier lives. We have seen this done. It is messy and contested, and it's never over, because what you're putting in place is a system that can adapt to constant change, anticipate it, and deliver genuinely agile, responsive services.
Thank you very much, Niamh. We've received some great questions so far. As a reminder, if you have a question you'd like to submit, there is still time. Just type your question into the questions box on your GoToWebinar panel. The first question we have, Niamh, is, in your experience, how can we, as leaders, cope with unpredictability while the transformation of the new design is being implemented?
Well, I guess the answer to that question is that unpredictability is a feature of organizational life today, and that's, I guess, one of the starting assumptions of building a new and more agile health and care system. Excuse me, I've got a bit of frog in my throat. And what you're trying to do here is create a system that can cope with that unpredictability better. For me, I guess the key is how leaders, particularly in a new system, respond to that unpredictability during the transformation process. Pardon me. And how those leaders behave and respond to that unpredictability will send a strong signal to the system through the process of transformation. I guess I would say in our experience that we guide and support leaders to suppress their natural instinct, which is often to make an immediate response to any new demands that come up through the system. Replacing this instead with an approach to collective discussion, considered views around what should be the importance given to a new demand that has come on, where it fits in with the transformational agenda overall, and how they can create, as I said before, the cover and the space that they will absorb some of those shocks on behalf of their front line, not pass them on to their front line, but as I said before, leave their front line with the space to get on with the innovation and testing the ideas that they've given them the permission to do. I hope that answers that question.
Yes, I think it probably does. The next question, when you were talking about the dual operating system, specifically the innovation networks, does someone need to lead these? And if so, how do we ensure continuous motivation?
Yes, you do. You do need leadership for the innovation networks, but I would strongly discourage that leadership is imposed from outside of the network. Um, we are working towards the principle of peer accountability. So it's very important that the network of volunteers or champions that come together to work on an idea select the person they think is best placed to lead that particular piece of work, bearing in mind that what we're talking about are often quite short projects in terms of time limitation. We encourage the clients we work with to think about chunks of work in quarters, so in 3 months. Think about something that could be quite manageable over that period of time. Choose the person that you think is best positioned across your network to lead that particular piece of work. But again, that leadership is about facilitation. It's about facilitating the group to work through the plan that they've got for designing and developing, testing, iterating, and reporting back to each other on that idea. It's not about taking sole ownership of making the idea happen. It's again moving away from that idea of command and control to an idea of facilitation and shared ownership and shared self-management across the whole network. So yes, coordination is very important, but I would steer away from using the word leadership too much, because people have a tendency, particularly while you're making a transition from command and control systems to self-management, to look to a leader for decision making, when in fact what you're trying to do is empower the network to make their own decisions and be accountable to each other. What I would say, though, is ensuring continuous motivation. A very powerful driver of continuous motivation is a success, but can also be failure, particularly if you feel that together as a group you are learning something and you're learning it collectively and you're sharing responsibility for that learning. Another powerful driver of motivation is having service users involved from the very beginning in these networks. Service users can be hugely powerful and enthusiastic ambassadors for new ideas, and having them as an integral part of the group can be absolutely critical as a motivator to the whole group.
Great, thank you for that, Niamh. We're going a little over time, so we're going to cut the Q&A session here, but if we were not able to get to your question, we will follow it up by email. As a reminder, this webinar series is running in parallel with our healthcare evaluation webinar series. The next health transformation webinar is on the 15th of March, where we'll be talking about improvement. How are we building a culture of collaboration and innovation that harnesses our collective intelligence for improvement? If you have any colleagues who think may be interested in this topic, please feel free to forward the webinar invite. Thanks again for joining us, and we hope you'll be back at the next Optimity Advisors webinar. Thank you.